Welcome, everybody. Shavua Tov, and thank you so much for your participation today. Today is a very important gathering and meeting that we can, as a community, confront this challenge of the third wave of COVID-19. And when we work together in unity as a community, then no one is alone. And most importantly, we arm ourselves with the facts, with the context, with the understanding. And that's what we have such outstanding panelists to help us to do. But also we realize that at the same time, we need to keep ourselves safe and maintain all health and safety protocols, but also to have a spiritual response. And that is also what today is about. But let us begin immediately and ask Dr. Richard Friedland to present and give us a context of where we are holding, and to thank Dr. Friedland for his unstinting support to our community and his leadership of his hospital network in bringing health and healing to South Africans across our country. Thank you so much, Dr. Friedland.
Good afternoon, Chief Rabbi, and everyone out there. And thank you very much for allowing me to join this panel of esteemed guests. I had hoped that I would never have the need to present again on COVID-19. But unfortunately, the reality that we face is indeed a very serious one. And here in the Gauteng, unfortunately, we are in the eye of the storm, with things set to get a lot worse than they currently are. Over the last 15 months, we have treated about 75,000 people with COVID-19 in our primary care centers, in our emergency departments, and in our hospitals. We've had to admit over 44% of them, and 25% of those patients have required some form of critical care. And that just demonstrates the virulence and the severity of this pandemic and what we're dealing with. And I wish I could sit here before you today and say that now, with all the knowledge we have, some 15 months later, the virus is a more milder form, we can contain it better, and that people are doing a lot better. But in reality, we're seeing a higher death rate, certainly with the patients being admitted now in the Gauteng. It may well be because patients are being well managed at home by their general practitioners, by the likes of the various programs run by Hatsola and the crisis management team in KZN, and the CSO in Hatsola in Cape Town, and other organizations. And we as hospital groups are only seeing the more severe cases. But as I walk through our COVID units, and I visit them on a regular basis several times during the week, I see people struggling to breathe, people fighting to survive this shocking pandemic. And every day we are reminded of the pain, the suffering, and the enormous loss that it brings. And so I want to be abundantly clear, colleagues, that in this crisis, there can be no place for a lackadaisical approach to this. And I want to talk about what that approach should be at the end of these slides, because a lot of people are saying to me, well, there's very little we can do. Perhaps government regulations aren't enough. Actually, that's irrelevant at the moment. There is an enormous amount that we can do as communities across South Africa. And I want to talk to those in some detail a bit later. Before I get onto the numbers and show you what's happening across the country, I also want to pay tribute to healthcare workers across the public and private sector. They've been at it for some 15 months now, and you only have to be in our wards or witness what our paramedics are doing on the ground across the public or private sector, and come and see our physiotherapists trying to get patients to breathe who are desperate to breathe in these COVID units, to understand the enormous sacrifice that healthcare workers are making, and feeling pretty exhausted and overwhelmed at a time like this. And so my appeal to everyone here today is to catch a wake up. This is extremely severe, and we should all be doing everything we can to prevent a single death, to prevent people having to be admitted to hospital. That's my overarching plea as I begin this presentation today. As I've always shown you, just to point out what happened last night in South Africa, we had 9,300 new cases. Over 70% of the new cases are now in Gauteng and the Western Cape. You can see here on the left. And as I move my laser pointer, I just want to point out, be careful of the statistics you're seeing on a daily basis. They are somewhat understated in terms of the active cases we're seeing in the Gauteng. Certainly 60% of the cases we're seeing, active cases, are in the Gauteng, and there is a lag factor at play. As I've always pointed out, it's far more important to understand what's happened over the last 7 days. And as you can see across all the provinces here on the right, there have been very significant increases, particularly in the big provinces of Gauteng, the Western Cape, Eastern Cape, and KZN. And we are seeing somewhat of a recovery in the two smaller provinces of the Northern Cape and the Free State. And this is the trend over the last month. You can see very clearly here as the Gauteng starts to peak. The Western Cape is a good 4 weeks behind us, and I'll show you that, as is the Eastern Cape, and KwaZulu-Natal further behind. Now, this graph really shows you the average daily cases as they occur, and you can see the peak of the first wave was at about 12,300 cases, 17,800, and we're now at about 6,800 cases in total. So 50% of the first wave, and we are effectively, in a technical definition, at least 30% of the active cases we saw in the second wave, and so we are technically in a third wave right across the country or nationally as a whole. You can see that initially there was a very gradual climb. This was because this third wave has been driven by the smaller provinces and now the Gauteng. In the second wave, it was 3 provinces all at once, Eastern Cape, Western Cape, and KZN, with Gauteng following last. And in the first wave, it really started in the Eastern and Western Cape, and then lastly in KZN. What we've done here is superimpose the 3 different waves on each other to understand where we are. And what you can see is a much slower trajectory here in the third wave, this orange line, but now beginning to rise rapidly as it will eventually surpass, we believe, the peak of the first wave through the winter months. We're about 1,000 cases behind where we were in the first and second wave, again, because this is purely being driven by the Gauteng at the moment and the 2 smaller provinces. I've always put this up to show everyone what we consider is the lead and lag indicators. The number of cases testing positive, that's the dotted line. You can see here it's the lead indicator and it's still climbing, whereas the lag indicator is this 14-day average number of cases. And it's only when these 2 cross do we reach a peak, as we see here, and we start recovering, as we saw in the second wave and in the first wave over here. And we believe this will widen somewhat for the next 3 to 4 weeks before we begin to see a potential lessening of cases. In terms of positivity, this is probably the most accurate number we have in measuring this pandemic. It's very difficult to look at the number of deaths. We know that they are understated, in terms of recoveries versus active cases. We know that they are not as accurate. And in terms of hospital data, that too is not as accurate as it could be. But one thing that gives us a very clear indication of where we are in this pandemic is the positivity rate. The number of people who are tested on a daily basis who test positive. We know the World Health Organization defines recovery as anything under 5%, and we were certainly in that zone after the second wave. We're well over that 10% threshold and are now climbing. If you look at the right-hand side, what is positive about this is that we're certainly testing enough people. And why is it important that we need to test as many people as possible? Because the more people test, the more we're able to self-isolate and quarantine people and prevent the spread. And as you can see in the first wave, we certainly weren't testing enough. The virus got ahead of us. We were acquiring tests, and the positivity rate rose to 28%. Similarly, in the second wave, we weren't testing enough. It took us by surprise how quickly it happened after the first wave, and the positivity rate rose to 32%. We're hopeful with the number of tests now being conducted, almost equivalent to what was in the second wave, that we won't see that high level of positivity rate and that we can get ahead of this virus in this third wave. Now, I want to spend some time just looking quickly at the Gauteng, the Western Cape and the Eastern Cape. You can see a massive increase in the number of cases. We're about 1,000 cases off the peak where we were, but a 72% increase and significant increases over the last 4 weeks now in the Gauteng, very close to what the peak was on the 8th of January. Now, this was an average. On the 8th of January, we saw 6,900 cases, and last night we saw 5,900 cases. So we're about 1,000 cases off the peak. Again, having a look at how the first wave compared to the second and now to the third, we started off much slower, but we are ramping up, and the next 2 to 3 weeks are going to be particularly severe here in the Gauteng. Looking at the Western Cape, they were in a good period of recovery here. As you can see, they've now breached that period of recovery. They're not yet within a third wave. They're not at 30% of the cases in the second wave, but we believe that they are only about 4 weeks away from where we are in the Gauteng. We're seeing a similar rise in KwaZulu-Natal, but again, nowhere near where they were in the peak of the second wave, but nonetheless are coming out of that recovery phase pretty quickly, and exactly the same picture now in the Eastern Cape. And so we believe the progression will probably be from the Gauteng, Western Cape, Eastern Cape, and then followed lastly by KZN. I've always put this slide up to show the reproduction rate, or the RT number. As we know, we want to ideally get that between 1 or less than 1. And over 1 means the virus is out of control and that there is an outbreak. And it is a level of infectivity or contagiousness. And as I've shown before, measles, 1 person can infect up to 18 people. Well, let's have a look at it here for South Africa. You can see as a whole, South Africa is now sitting at 1.41 and has done so for quite a significant time now. And all provinces are now above 1, with the Gauteng as high as 1.57. So the pandemic is raging across South Africa. It's yet to reach third waves in specific provinces other than the Gauteng and smaller provinces, but all indications are that that will happen over the coming weeks. I want to end by just showing you what we're seeing in South Africa in terms of private sector hospital admissions. This was only until the 3rd of June, but I can tell you as of last night, we're now admitting across the Gauteng just over 520 cases a day in the private sector. And this is putting enormous strain on our emergency departments and hospital beds. I think right across the sector, we are fighting to open as many new beds as possible to make space for patients. And we're asking you for your patience in this regard. Our staff are stretched. Many of the groups are employing more doctors, more nurses, more social workers, more clinical associates. But we are seeing an enormous admission pressure at the moment. One of the problems leading to that admission pressure is that people are staying longer in hospital. And in this wave, we are seeing a 20% increase in the length of stay. And so people are staying longer in hospital over this winter period, exacerbating the shortage of beds that we're seeing here in the Gauteng. And then something I wanted to point out to you is that as we see this increased pressure on beds and demand for critical care, we see a stepwise change in mortality. And these are the first two waves. And what we're now seeing in the third wave is no different. And so mortality of patients who are now coming into a hospital is rising. And this is our single biggest concern at the moment. I want to end by saying what it is we can do as communities across South Africa. We aren't helpless. In fact, there is an enormous amount we can do. Probably the single most important thing we can do is to be hypervigilant, is to maintain all the non-pharmaceutical measures we've had in place and not be flippant about it. Unfortunately, I've seen many pictures of people going to vaccination stations, not wearing masks or wearing them around their necks, people socializing at communal gatherings. And my appeal is that we shouldn't be doing any of that. We should be cutting back on socializing completely. If we're shopping, we should try to be shopping online as much as possible. And we should avoid socializing with friends and family in our own homes. It's a critical way of preventing further death and further suffering across our communities. The second issue is that if we have comorbidities, we should be doing everything in our power to optimize them. If you have high blood pressure, if you have diabetes, if you have asthma, any cardiovascular condition, make sure that you are optimizing that. We are definitely seeing people with comorbidities that are not well controlled being far more susceptible to this virus and having a far worse outcome in terms of their clinical picture. And so there is something you can really do about that if you are suffering or have one of these chronic illnesses. The third is obviously to make sure that if you are over 60, that you get the COVID-19 vaccine. I'm sure we're going to hear from Professor Schoub and Dr. Noach about how important that is to be vaccinated and what the logistics are around it. It's not foolproof. You can still get COVID if you've had this vaccine, but it does offer a significant amount of protection. And I would really urge everyone who is able to get this vaccine to do so. And the last point I'd like to make is that we have yet to see a flu season in South Africa. Last year, we missed it completely because we were in such a significant form of lockdown. There was effectively no flu season. This year, in the month of May, we've seen probably 30 to 40 cases of influenza or flu. But if you can get out there and get the flu vaccine, it is not too late. And you can certainly avoid further pressure on general practitioners, on the healthcare system, and indeed on hospitals if you're able to prevent getting flu. And particularly the confusion that arises because the symptoms are very much the same. Lastly, I've put this one up about the Netcare Family Connect line. I'm sure every group out there has their own form of communication. We recognize that communication during this pandemic is problematic. I think if any of you have been in our COVID units, you'll understand how difficult it is and how many hours our doctors and clinicians are spending in these units and how difficult it is to have proper communication with family and loved ones of patients who are in the hospital. So we have this Family Connect line that you can contact. It's available weekdays and weekends, and we can certainly relay messages to your loved ones. We can certainly get feedback for you on a daily basis. And I would just appeal to the entire community to recognize the enormous strain that all hospital groups and all providers and paramedics and healthcare workers are at the moment on the front line, and recognize that they are doing their very best. We're not going to turn anyone away. We're not going to deny help to anyone, but there may certainly be delays in offering that level of care, and our communication may not be ideal at all times. Thank you very, very much, Chief. I'll stop there.
Thank you, Richard. Thank you so much for your time and your dedication, and for always being available to help guide our community at these critical moments. I'd now like to ask Professor Barry Schoub to share with us some of his thoughts. Professor Schoub is the chairman of the Ministerial Advisory Committee on the vaccines, and he's going to be sharing with us some perspectives from that committee. Thank you, Professor.
Thank you very much, Chief Rabbi, and thank you very much for inviting me onto the webinar. Good afternoon to everybody. Thanks for the opportunity for clarifying a lot of issues around COVID vaccine in South Africa. Now, COVID vaccines really have, in South Africa particularly, have had a bad press. It's not unique to South Africa. Of course, many countries around the world also have a bad press around COVID vaccine. But I think a lot of it is really due to ill-informed and misinformed journalism. And really what I'd like to do now is just very briefly go through some of the science and what lies behind the scientific evidence which is given to the Department of Health, to the Minister, to the Department of Health as an advisory. Now, there are 3 ministerial advisory committees, what we call MACs, M-A-Cs. The original one, which was chaired by Professor Salim Abdul Karim, Slim Karim, sure many of you are familiar with him, he's very much on TV and so on. And it is now co-chaired by Professor Kuleka Mulsilana and also Professor Marion Jacobs. Then there's the MAC on socio-behavioral issues, which I believe, Chief Rabbi, you also are part of that, and together with other faith leaders and sociologists. And that is chaired by Bishop Malusi Mburwana, who's the chair of the South African Council of Churches. And then we have the Ministerial Advisory Committee, the MAC on vaccines, or what we call the VMAC, which is chaired by myself. And that is one of the younger ones. That was actually came into existence in September of last year. Now, all participants in all the MACs do it on a completely voluntary basis. None of us received any remuneration. None of us are part of the Department of Health, except for some of the Department of Health members, of course, of the advisory committees. We don't serve as spokespeople for the Department of Health. We're not responsible to the Department of Health. And as far as the VMAC is concerned, it provides scientific evidence-based knowledge to the planners who then plan the vaccine rollout. So the MACs are really advisory bodies. They are not executive bodies, they're not decision-making bodies. They purely provide scientific evidence. Now, with regard to the VMAC, this consists of, currently we've got 18 core members, and these are really the leading scientific brains throughout the country. We represented in all throughout the country. And they are really the experts in vaccinology science, immunology, virology, vaccines, ethics, and so on. Many of our participants sit on international bodies such as the World Health Organization and other international bodies as well. In addition to the core committee, there are 5 work streams which also have expertise outside the MAC, and they deal with the various aspects of vaccine expertise, of vaccine science. And then in addition to that, we have what we call technical working groups, which deal with particular issues. And the technical working groups harvest in expertise from the rest of the country and also international experts as well. So we have 4 of the top international experts on the technical working groups. One of them is actually Dr. Barney Graham from the NIH, who actually designed the insert of the Pfizer and the Moderna vaccines. Now, the way that the MACs function is that there are weekly meetings. We have weekly meetings every Thursday afternoon, which lasts about 2 to 3 hours. They're quite intense meetings, and all the science is then presented, it is digested, it is discussed, and we get a consensus opinion to provide onward scientifically based evidence. In addition to these weekly meetings, there are also many extraordinary meetings when particular issues come up. And then in addition to that, there are the meetings of the work streams. And in addition to that, there are the meetings of the technical working groups. So you can see that the MAC is quite a busy, ongoing program. In addition, we also meet with all the manufacturers. And the VMAC has met with all manufacturers of all the vaccines which are currently available throughout the world. We haven't yet met with the Cuban vaccine. That's the only one we haven't met with yet. But we certainly met with the Chinese vaccine manufacturers, the Russian vaccine manufacturers, and all the other manufacturers around the world as well. Some of them we've actually met with several occasions. The upshot of all of this is what's called an advisory. This is a formal document which then gets sent to the Minister of Health and then to the Director, and as well as the Director General of Health. From there, it is their property. It is not the property of the MAC, we don't have it. We can't do anything with it. It belongs to the Minister of Health. The Minister of Health then presents it to what's called the NCCC, the National Coronavirus Command Council. From there, it goes to the Interministerial Vaccine Council, which is headed by the Deputy President. The NCC is headed by the President. And they make the decisions together with the other cabinet ministers and the other departments. Because obviously the advice that we give from the MAC is a scientifically based evidence which has to then intercalate with other issues, financial issues, distribution issues, rollout issues, and so on. As I said before, this is the property of the minister. So some of it does go onto websites, various websites, some of it doesn't. And unfortunately, the VMAC, for whatever reason, the department is a bit reluctant to put ours onto the website. It's very little that we can do as a MAC. As I say, these advisories don't belong to us. Now, the important thing which I really want to discuss very briefly is that these issues are, as I've just outlined now, the workings of the MAC are complex and they're difficult. They're not as simplistic as journalists often try to make it out in the media. And also, in fact, some of my colleagues try to make it out in the media. And the important thing, which I think everybody must realize, is that South Africa is in a uniquely, almost uniquely difficult, compromised, and challenging situation. And the reason for this is that South Africa is almost unique. It's also some other Southern African countries in having as its virus, dominating the virus spectrum, the 351 or 501v2, what's now called the beta variant of the virus. Now, this is the most resistant virus to immunity, either immunity once you've been infected, as well as vaccine-induced immunity. This is very unfortunate. This is very bad luck for the country, but almost the 100% of viruses which have been genotyped in our laboratories, there's a network of 5 or 6 laboratories around the country, have been this particular beta variant. And this is really the king of resistant viruses. And because of that, we cannot afford the luxury, which most countries around the world can do in terms of choice of vaccine. We are limited to the choice of vaccine to 2 vaccines, either the Pfizer or Moderna. Well, Moderna is not really generally available, but it's the same kind of vaccine, the Pfizer vaccine and the Johnson & Johnson vaccine. That's point 1. Point 2, we now have very recently a double whammy in the sense that the vaccine pipeline has been compromised because of what's happened in the facility in Maryland, United States, where they make the active pharmaceutical ingredient. That's the basic starting ingredient, which then gets sent to various centers, including the Aspen facility, which then fill and finish the vaccines. And this particular facility called Emergent Biosolutions in Gaithersburg, Maryland, they had an inspection by the FDA of the United States, the regulatory body of the United States, and they found that this particular factory was deficient in its good manufacturing practice, what you call GMP. As a result, it was closed down temporarily, and their stocks had to be destroyed. So about 60 million doses of vaccine had to be destroyed. The facility in Gqeberha, which is in the Eastern Cape, the Aspen facility, unfortunately 20 million doses, which we which were or 10 to 20 million doses, depending on further inspection by SEPRA, which is the local regulatory authority, may well also not be available. So unfortunately, we're now almost dependent at the moment on the Pfizer vaccine. So this is an unfortunate situation. All of these situations are outside the control of the minister, outside the control of the Department of Health, outside the control of the VMAC, outside the control of anybody in this country. These are unfortunate realities which we have to face in terms of vaccine supply for the vaccine rollout. So we do have bad press, and this generalizes to the social media and to individuals and to the gossip columns, and sometimes it reaches hysterical proportions in terms of the extent of the blame which is made. But this, as I said, this is really beyond the control of any of these bodies in the country. And the problem with this kind of gossip or ill-informed criticism is it can be harmful. It can be harmful because it undermines trust. It can be hurtful because it's hurtful to those who are bereaved, who have lost loved ones to COVID. And also it can be damaging because we do need to, as Dr. Friedland mentioned just now, we do need to maintain those non-pharmaceutical infection prevention measures. So I hope I've given some kind of perspective behind the vaccine. We do hope, earnestly hope, that it will improve very soon. But thank you very much for listening. Thank you, Chief.
Thank you, Professor Schoub, and thank you so much for not only the service you're doing for the country, but also our community. In both you and Dr. Friedland being on our medical advisory panel, for the shuls. And I want to just take the opportunity to thank you for your efforts in that. Professor Schoub recently drafted even tighter protocols for our shuls during this time. And I want to take also the opportunity to compliment our shuls for their total dedication. We had a very big meeting which Professor Schoub and Dr. Friedland addressed of the leadership of the shuls, the gaboyim, the rabbis, and there's been such commitment of our shuls throughout this, and I want to compliment our shul leadership on that, and to thank you, Professor and Dr. Friedland, for your efforts in guiding our shuls through that. Okay, thank you so much for your presentation today. Dr. Ryan Noach is CEO of Discovery Health, and asked Dr. Noach just to present to us on an understanding of the vaccine rollout, what we can expect, and any other insights which he has from his unique perspective. Thank you, Dr. Noach, for your time today and for everything that you and Discovery Health are doing.
Thanks very much, Chief Rabbi. Thanks for the invite to talk. And thanks very much for the interesting addresses from Professor Schoub and Dr. Friedland. Really important insights and important warnings for the community to take heed of. I'm going to share a presentation. Rabbi, you can just let me know when you can see it clearly. I'm sharing it now. And I'm moving into presentation mode.
Yes, we can see it clearly.
Can you see that clearly? Great.
Yes.
Okay, so I have quite a few slides. I'm going to zip through some of them because between Dr. Friedland and Prof. Schoub, they've covered some of the issues. And as per the rabbi's request, spend most of the time on vaccination. Just a couple of important insights along the way. So from a perspective of the waves, Dr. Friedland covered that brilliantly. There you can see how clearly the Northern Cape and the Northwest have really led this particular third wave. And the important news here is that you can see on this slide here that the Northern Cape, it actually looks like it's reached the peak of the third wave. It's been the worst of the three waves in the Northern Cape, and they seem to be coming down the other side. And I'm going to support that with some of the reproductive rate data shortly. Here is Gauteng on the top right-hand corner. You can see in the view of the last 100 days of Gauteng how steep that acceleration is. And on the bottom right-hand corner, you can see how the third wave is beginning to rise to the proportions of the second wave over the 15-month view. I think Dr. Friedland covered this. Let me pause here just to say something that you know, but to share with you data out of Discovery Health's member experience that's extremely relevant, and I think very important to explaining the prioritization of vaccination at the moment. As you can see on the left-hand side, it shows you in the red histogram chart the number of members admitted to hospital as a result of a consequence of COVID-19 infection. And in the yellow dot on that same chart, the proportion of positive members admitted, requiring admission to hospital when they contract COVID-19. And what's obviously clear is the steep upwardly trending line, with more than 50% of adults who are 70 years of age and older requiring admission to hospital post-COVID-19 infection. Now, this is particularly relevant because it justifies the prioritization of the elderly as the first to be vaccinated.
Dr. Noach, I think we've lost connection.
I don't know what happened there. I'm back, Rabbi. Can you hear me now?
Yes. I think please continue.
Sorry, I don't know what happened there. Let me go back to sharing. Can you see the slide?
Not at the moment.
See it now?
Yes.
Okay, so what I was saying is if you look at members living with chronic illness, on the right-hand chart, you see those orange histograms and the numerals underneath representing the number of chronic illnesses they're living with. And as they live with more chronic illness, so you can see the proportion requiring admission to hospital. Of particular relevance are hypertension, diabetes, and hypercholesterolemia, which are the biggest drivers for admission to hospital. And so we would advocate for the next population to be vaccinated to be those that are younger than 60 years of age, but living with chronic disease. This is proven particularly difficult in other countries around the world because the proof of living with a chronic illness is sometimes difficult to obtain. For members of Discovery Health, obviously, we have that evidence, but at a population level, this is quite difficult to manage. We'll have to see what's advised next. This chart shows you Discovery Health members that are being admitted to hospital across the 3 waves. And what I wanted to point out to you is that we are on our way up, as Dr. Friedland showed in wave 3, notwithstanding which the admissions in wave 3 have reached the same level as the peak admissions in wave 1. We're still quite a distance short, about 30% below the peak in wave 2, but we have already reached the peak of admissions in wave 1. As we sit here today, in Discovery Health, we have 2,012 members who are currently current admissions on the go, of which 526 of those members are currently in ICU and 275 of them are requiring ventilation. So to substantiate Dr. Friedland's point, there is a lot of morbidity around. Dr. Friedland described the reproduction factor, and there is only really 1 province or 2 provinces that are below 1 at the moment, Northern Cape and the Free State. They've both been through quite an exaggerated wave 3 already. You can see Gauteng's reproduction factor is standing at 1.34 at the moment. And why this is very important is because of this study that the actuaries at Discovery Health have prepared. The extent of a wave in any particular region is a factor of the underlying immunity in that region. In other words, how much resistance exists already in a region, multiplied by the reproduction factor or the rate of spread of COVID-19. And so what you can see in this first column here in blue is a mathematical representation working back from the excess natural deaths in those provinces for a proportion of the population that we at Discovery believe have already been infected with COVID-19. So a lot of words there, but let me simplify it with a Gauteng example. 43% of people living in Gauteng, according to our calculations, have already had a COVID-19 infection sometime over the last 18 months. Now, our mathematical model is corroborated by antibody studies that have been done by various organizations, which come out with similar results. The green column tells you from our actuarial calculations, the reproductive factor required to cause a very steep upward spread and a third wave of COVID-19. And you can see for Gauteng, the tipping point for a very steep third wave is 1.8. The current reproductive rate in Gauteng on the 7th of June, so a few days ago, was 1.3, and unfortunately that has ticked up to 1.5 now. So all of this is pointing in the same direction that Dr. Friedland was describing, which is that we are facing the potential of an extremely severe third wave, and we're only seeing the beginning of it now. Quite relevant this, if you look at, for example, the Eastern Cape, where there have been a large number of infections already, probably about 90% of people in the Eastern Cape already infected once before with COVID-19, and therefore the reproductive factor you need for another severe wave in the Eastern Cape is a reproductive factor in excess of 11, where the reproductive factor there now is 1.4. So it's quite likely in our actuarial model that the Eastern Cape experiences a very mild third wave, if any third wave at all. A mild tick up in infections is more likely than a wave in the Eastern Cape. The bad news about this, ladies and gentlemen, is that our data shows conclusively, and we've audited this data very carefully, that a large number of people are showing evidence of reinfections. Unfortunately, what our data shows is that Discovery members who contracted COVID-19 in the first wave have again contracted COVID-19 in the second wave. And in fact, 3 members, it's only 3 out of 3.7 million people, but 3 members have now tested positive 3 times. And we've been in personal contact with all 3 of those members and confirmed the status of those 3 positive infections. The bad news about this is that our data shows that you're at about a 33% risk if you've had COVID-19 before of catching it again relative to the rest of the population. So based on a population model where the chances of the population catching COVID-19 at the moment are 1, your chance if you've had it once before is 0.3. So there's a 33% chance of catching it again. Now, this is particularly concerning because from a clinical perspective, it leads us to believe that the immunity is not lasting, does not endure, and consequently, there is a risk of reinfection. So moving quickly to the vaccination rollout then, emphasizing how important this is in the context of this third wave and the reinfection data. The starting point is just for you to understand the national rollout plan of vaccinations. As you see in this table on the left, the Sisonke trial completed almost 500,000 vaccinations, primarily of frontline healthcare workers, but also in the last week of the trial of healthcare personnel. The phase that we're in now, which is called phase 2B of the vaccination campaign, vaccinates healthcare workers, the balance of them, plus those people in South Africa over the age of 60 years. And in combination, phase 2B should target 6 million people. And so we are wanting to vaccinate these 6 million people by midwinter, by the middle of August. The Department of Health wants to move to phase 3 of vaccination in September. And our aspiration is to make sure we're done before September, if possible. We will then move on to the other groups in the population. The segmentation of who receives this first and the prioritization has yet to be concluded. We await for Prof. Schoub's recommendations to the Department of Health and their final decision on those prioritizations. But that encompasses vaccinating 41 million people, 4.8 million between 50 and 60, and then about 7 million between 40 and 50, and 23 million between the age of 18 and 40. It's important also to take into account 12 to 18-year-olds. There is evidence that's emerged of safety in vaccinating these age groups. The FDA in America has recommended this under emergency authorization, and it's likely, and I'm hopeful, that we'll do this in South Africa too. There are 6.3 million people in South Africa between the ages of 12 to 18. So between May and July, as you see on this top right chart, we are receiving 11 million doses of the Pfizer vaccine. This is far fewer doses than we originally anticipated, because we had anticipated receiving, as you see in gray here, from August, Johnson & Johnson vaccine starting in May and moving all the way through this period. So we are very short of vaccine supply relative to the plan that we had in mind. Prof. Schoub explained that the Johnson & Johnson vaccine is withheld, and we saw the recommendation from SAPRA this morning that those doses should in fact not be used in South Africa. So if you work out, taking into account this supply of vaccine, what the run rate, the daily run rate of vaccination should be to use up all the doses, you see that here on the left-hand side. In May, we needed to do 70,000 on average per day. In June, 150,000 on average per day. And in July, 220,000 on average per day in order to use all the stock that's available. I should make the point that there's a lot more complexity than you would imagine in the QA process and in the distribution process. But assuming all that complexity is solved by very lean distribution, we should achieve that run rate. So now where are we in terms of the run rate? Well, I told you those targets, the May target and the June target. What you can see on the bottom right here of this chart in the block is our actual run rate in May was 65,000 per day, close to the 70,000 target. In June, our run rate is currently 90,000 per day, well short of the 150,000 per day target. I should make the point that many of the sites that are administering vaccinations are public sector sites, and it's transpired that unfortunately the digital record keeping on EVDS at these public sites has not been complete. And as a result, there is probably a higher number of doses being administered that's not yet captured into the EVDS system. So in all likelihood, we expect this 90,000 to actually be quite a bit higher. So what does this mean in terms of our progress? Well, from a Discovery Health perspective, we've vaccinated about 76,000 of our members, being 2% of the membership. And from a country perspective, about 1.6 million people, being almost 3% of the country's population. If you remember that phase 2 target I spoke about earlier, those 6 million lives that we're targeting in phase 2 being healthcare workers and those over 60, we have already achieved 18% of that phase 2 target, which isn't a bad performance. I'm going to skip over this. Just to tell you from a Discovery Health perspective, we will be contributing 25,000 vaccinations a day to the national effort. We are extending our capacity at one Discovery Place to 4,000 per day. We are setting up 3 more mass vaccination sites, Joburg, Cape Town, and Durban, as soon as the supply of vaccines allows. The shortage of supply has not allowed us and many of the other private sector facilities to open the sites that we had in mind. And we have partnered with Virgin Active, where we have 4 open already and an additional 4 opening up after that. At one Discovery Place, we are running the largest vaccination site in South Africa at the moment, and we've delivered 45,000 vaccines there.
Doctor, if we could just make the screen a bit bigger. People are saying they can't see the detail on the screen. If you could make it slightly bigger.
Are you seeing the full slide screen, or are you seeing the presentation view?
I don't know. I don't know how to answer that question, but I'm seeing something smaller.
Ryan, it's the presentation view, not the full slide screen.
No, that's a pity. Let me see if I can fix that. There is a way to swap the screens, swap displays. Is that better?
Yes, much better. Much better.
Sorry about that. Okay, so this is very important. If globally, the effectiveness of vaccination has been shown to be very reassuring and really underlines the importance of a high velocity vaccination campaign in South Africa. What you're seeing across the top chart here are the infections themselves. And what you're seeing across the bottom chart is mortality. So for Israel, United Kingdom and United States, in the blue line, you see the number of the people in the population, proportion of the population vaccinated. And you can see in all 3 of those countries, steeply rising vaccination program. What you see in green then is the number of new COVID-19 infections. And you can see a precipitous drop in Israel, the United Kingdom, and the United States. Unfortunately, the Chile experience is an outlier experience. I think the difference here is that in Chile, they used a different vaccine. They used the Chinese vaccine. And despite a steeply uprising vaccination curve, having vaccinated more than 60% of the population, they have experienced additional waves of COVID-19, leading us to assume that the Chinese vaccine is not as effective as the others in preventing infections. However, let's have a look at the mortality data. Israel, the United Kingdom, and the United States, a precipitous drop in deaths following vaccination, all the way down to 0, no deaths per day. In Israel and the United Kingdom. In the US, they're still experiencing some deaths, although their penetration of vaccination is not at 50% yet. In Chile, you can see that the deaths do rise slightly, but nowhere near from the like the previous phases. Having increased. What this tells us is that Chinese vaccine, the Sinovac vaccine, is probably not effective at preventing infection, but may be quite effective, in fact, at preventing health members who've been vaccinated. Now, let me qualify this data and say this is very early data with very small numbers that are probably at this stage not yet statistically relevant, but still nonetheless very interesting to report. So what you're seeing in the brown chart on the left here is the cohort of non-vaccinated Discovery Health members, the 7-day rolling COVID-19 infection count. So new COVID-19 infections in non-vaccinated Discovery Health members, and you can see that in the brown chart. And the blue chart is members that have been vaccinated, but under 14 days. Starting on day 0 for each of these members, at the 14-day point, what is the infection rate? And you can see that under 14 days of post-vaccination looks very similar to the non-vaccinated cohort. What you see now, though, in green, very interestingly at the bottom of this chart, is the 7-day rolling average of new COVID-19 infections in vaccinated members 15 to 30 days after the first dose of the vaccine, and that's the Pfizer vaccine. And you can see a palpable and a material gap between the brown and the blue lines and this green line, leading us to believe, and keep in mind that this data is early and that there are low volumes here, leading us to believe that there are good signs that the Pfizer vaccine is already working for our vaccinated members after 15 days and is preventing infection. The same is true if you look at the pickup rate. Dr. Friedland spoke about the importance of this metric. And if you compare the positive pickup rate, the brown and the blue lines, very similar pickup rate, but the 15-day post-vaccination pickup rate is very low. Now, this is skewed by behavior. The people that, some of them that came for vaccination early may be more diligent, but at this early stage, this is very reassuring evidence. If we look also at morbidity, in other words, how sick people are getting from COVID-19, just concentrate on this bottom table over here. If you look at the people with less than 14 days post-vaccination, you can see that there were unfortunately members who got admitted and some who died as a result of COVID-19. But if you look at the cohort in the 15 to 30-day cohort, qualifying again, this is a very small sample size. There were only 3 members admitted and no deaths. And so we are hoping that these are the first signs, and we'll track this data as it emerges, that the vaccine and even just the first dose is working very well in our society. Importantly, people ask a lot about side effects. The data has been released from the Sisonke trial, and it confirms the satisfactory safety of the Johnson & Johnson vaccine. I'd love to take you through the detail, but the Rabbi has constrained my time, and so I'm going to move on. Just to say that in our Discovery Health data, we are tracking side effects after vaccination, and you can see a breakdown on this slide of the side effects post-vaccination. Keep in mind that this is an elderly cohort living with many comorbidities that have been vaccinated. There are side effects. All of these so far have been mild. There have been no deaths at all, and there's only been 1 hospital admission post-vaccination of our 75,000 members that we've vaccinated so far as a result of a vaccine side effect. There have been a couple of admissions for other reasons, although in these elderly cohorts, we'd expect that. Just to quickly round off the story and make the point that the economics of vaccination are very, very important. The World Economic Forum, as you see on the left-hand side of this chart, showed in their study together with Oxford University Economics that while vaccines will cost the world $38 billion by 2025, the savings, the return on investment to the world, the global GDP, is $466 billion. In other words, a 12 times return on investment of vaccinating the world. And really, in economic terms, makes sense to do so. And that's why today we saw an announcement by the G7 group of countries to say they will be donating 1 billion vaccines to developing countries to ensure rapid vaccination with COVID-19. While it's important and saves lives, from the G7 countries' perspective, from a return on investment perspective, it makes complete sense. Our health economic unit at Discovery Health has done a return on investment assessment for South Africa. And in our view, the return on investment is somewhere between 6 to 25 times, depending on which case we use for the speed of vaccination. It's really the speed that determines this. 3 last points, and then I'm wrapping up. The first is to say that it's very likely booster shots will be required going forward. We see all of the vaccine manufacturers doing R&D work on their boosters. Moderna's booster is in fact already in a clinical trial process. It seems pretty likely, particularly considering the variant emergence, that boosters will be required, and we're waiting and watching very carefully here. The second point is that children are going to be eligible for vaccination soon. The Pfizer trials have shown good safety in the younger populations, and I hope to vaccinate my own children as soon as the rest of the adult population in South Africa is vaccinated. And then thirdly, very powerful data emerging both in the media and in clinical journals around what's happening at a city level. And this is very interesting. There's been a report both about San Francisco, but very interestingly about this town in Brazil called Serrana. And this Serrana story is fascinating. It's a small town in the center of Brazil, which is going through a severe COVID outbreak. What they did in Serrana was they closed the borders to the town and they vaccinated the entire town. And guess what? New infections dropped to almost zero. Morbidity and mortality disappeared. And the town is like a little island now in the center of Brazil, completely COVID-free almost. And this is quite astounding. So it bodes well and underlines the importance of vaccination. Rabbi, I'm going to pause there. I've got some interesting material on long COVID, but I've run out of time, so I'm going to pause there and hand back to you.
Okay, thank you so much, Dr. Noach. That was fascinating and I think very reassuring to say that once the vaccination program is fully underway, that's going to be the beginning of the end of this very difficult times. And thank you so much for all of the information and for your very erudite presentation. Thank you so much, and thank you for all of your work. For your members and for the community, so appreciate it. Thank you, Dr. Noach, for your time today. Friends, we're coming to the end of our program. We're going to hear now from Lance Abramson from Hatzola to see what Hatzola numbers are from a community perspective, as well as Hatzola's involvement in the vaccine rollout. Because Hatzola has received a license to be a provider of vaccines. And I think this is very important to know for our community. And then please stay till the end. After Lance has finished his short presentation, we're going to be davening together. And I want to just say that it's very important when approaching a challenge like this. We do it from a medical health and safety point of view, but we also do it from a spiritual point of view, because we know as Jews, and this has been part of what it is to be a Jew for generations, that at the essence of the faith of what our Torah is about is that vaccines do not protect and doctors cannot heal without Hashem's blessings. And so we're going to daven together after Lance has presented and say Tehillim. I have a list of names of those who are sick and suffering from COVID that we will pray together for. And that will be just after Lance's presentation, which will then bring this gathering to an end. So Lance, thank you so much, and thank you for the remarkable work that Hatzolah has done for our community throughout this pandemic. The dedication of your professionals, of your volunteers, of everybody has been absolutely remarkable. You've literally held our community through this, and we want to thank you and Hatzolah for your incredible work. I know that you also work together with CSO Medical in Cape Town, and but we just want to thank you for you and CSO Medical in Cape Town and for everything that you have done. Hatzolah's dedication, we've always known you as emergency response, but really Hatzolah's been quite inspirational for our community during this time. So thank you, Lance, and please share with us.
Great, thank you very much, Rabbi. So the numbers I'm going to present today are obviously only for the Johannesburg Jewish community and not the CSO numbers down in Cape Town. And unfortunately, as we know, our community is going through quite a big wave of COVID infections. And so much so, can you see the screen share, Rabbi? Is it?
Yes, yes.
Great. So, and so much so that unfortunately this past week alone, we had 255 new patients onto our COVID program. And that number, 255, reflects the highest number of new patients in 1 week that we've taken onto the COVID program for all 3 weeks. In fact, on Thursday, we had 59 new patients on the program, and that was the highest number of patients that we've had in a single day over all 3 waves. So really, our Johannesburg Jewish community is seeing a very high number of infections at this time. And unfortunately, the bad news is it doesn't seem to be coming down. I spoke to the team just before this presentation, and yesterday and today, they have already had another 100 new cases that have been taken onto the program just in 2 days. That leaves us with a situation like this, where the first wave for the Johannesburg Jewish community at the highest, at its peak, we had 263 cases on the program, and that was the highest peak of the first wave. In the second wave, we had this situation over here. That little blip was the rage spike that rage caused. And then we peaked out at 333 cases, and that was the peak of the second wave. And then if you just look at this, it's really a staggering number. We are already at 446 active cases as of today in the Johannesburg Jewish community. And that's really worrying. Another interesting thing, if you look at this graph, is you've seen the stats that Richard presented on Gauteng, that the Gauteng numbers haven't yet reached their peak of their first or second wave. And yet, unfortunately, in our community, we are already well over that peak of that second wave, right up here at 446. And the other thing you'll notice is that, unfortunately, there's just no indication of a slowdown. Curve, that very steep curve up, is something which is very worrying, and something which we're going to have to watch and hope that at some point we see our peak in the near future and that we start to come down. In addition to that, the ambulances are transporting multiple COVID positive patients to hospital daily. As Richard said, it is becoming very difficult to find a hospital bed, which means that the ambulances are going to the hospitals, and the patients need to stay in the emergency department. Sometimes the emergency departments are also full, and the ambulances need to wait in the parking lot to be let into the emergency department. And that is a very challenging situation for our teams on the ground. We're also looking currently after 63 patients on home oxygen. And those patients are sicker patients, they need home oxygen. And obviously what we're trying to do there is to keep these patients out of hospital for as long as possible. And that frees up the beds in the hospital for those patients that need it. And those patients that can be treated at home are kept at home and monitored at home, and that's very important. Some interesting stats over the last over a year. We've already monitored and cared for 3,408 COVID positive patients. And the team of people made up of full-time employees and volunteers have made over 69,000 phone calls to patients to check on their stats, their vitals, to record those vitals and put them into a system which monitors and tracks those patients. It's a staggering number, 69,000 phone calls by the team of volunteers. The patient deteriorates, we send a nurse to visit them. The nurse carries out a more clinical assessment of the patient. Nurse is also able to draw bloods where required so the doctors can see, have a better idea of what is going on with that patient. And since so the nurses at the moment are seeing between 80 and 100 patients a day. And since the beginning, the nurses have done over 4,890 home nurse visits. And that's to collect that information from patients. That's since the beginning of COVID. We've moved 398 patients off the program and into hospital from the start. That excludes patients that weren't on the program. Obviously, not everybody elects to choose to join the program. And we often take people to hospital who weren't on our program, deteriorated suddenly, and we had to move them into hospital. The 398 patients were moved off the program and into hospital. The advantage there is that when we move them off the program, it's done in a much calmer fashion. It's not an emergency. We know that this is coming. We've been monitoring them for a while. It's not a sudden deterioration in the patient, and so it's not, not a surprise requiring an emergency call out. This is some interesting stats on the vaccine, which we've touched on already today, but we have had already 238 patients to date on the program who had previously received a vaccine, some sort of vaccine. 171 of those had received the first Pfizer shot. Nobody yet has received the second shot on the program. So 171 people have received the first Pfizer shot and contracted COVID afterwards. I haven't broken down the timeframes here. That would be interesting to go into, but just an important message here for the community that if you've had your first Pfizer shot, you cannot let down your guard and stop wearing your mask, stop socially distancing, and stop sanitizing. You need to keep your guard up until you've had your second Pfizer shot and some time has passed that you have full immunity. We've also had 83 patients on the program that received a J&J vaccine, and then 2 AstraZeneca and 1 Moderna. Those are obviously people who came from overseas and then contracted COVID here. And the vast majority of these patients, and including the J&J vaccine patients, had their patients, got COVID early on after receiving their vaccine. So the full immunity or the full effect of the vaccine hadn't yet taken effect. We've only had 38 patients out of all of our patients who had been fully vaccinated, meaning, a month after the J&J vaccine. And of those patients, only 1 fully vaccinated patient was hospitalized, and that patient has since recovered. So that's very important. As Barry was saying, that the real power of the vaccine is to keep people out of hospital and to prevent mortality. That's really what we're looking for until there's been a very broad vaccine rollout, and then we'll see the vaccine being effective, hopefully even to prevent COVID. Those are just some of the numbers. I'm going to leave those up while I talk about the Hatzola, our little vaccine center, which we hopefully will have up and running. But just those 3 numbers. The top one is if you contract COVID or worried or have any COVID questions, if you phone that number, our volunteers will be able to assist you. Our emotional wellness line, if anybody is struggling from the emotional stress that is abundant at this time, you can call that number and one of our volunteers will help you. And the bottom number is obviously the standard emergency Hatzola line for medical emergencies. While I leave those up, so we received this week, as you mentioned, our license to open our own vaccine site. We are very excited about this, and this is the most important national project that has been rolled out, in many, many years, decades. And we're privileged and honored to be taking a part in this vaccine rollout. And we will be setting up our vaccine site in the heart of Glen Hazel, and hopefully making those vaccines accessible for the community around there, easily accessible. And it will probably be about another 2 weeks before it's up and running. And that's because there are still other pieces in the puzzle that are falling into place now. For example, the registration on the EVDS site, we're registering with the vendors to receive vaccine. It's also very important for the community to know that the vaccines will still be administered as per the government guidelines, the Department of Health guidelines, and that currently is to 60s and above. And for now, you know, that's who the vaccines will be administered to. So anybody who's registered on the EVDS system and gets their voucher, from about 2 weeks' time, will be able to come to Hatzola in Glen Hazel and will be able to receive their vaccine there. We're hopeful that as things open up and as the rollout gathers steam, we will be able to really focus on our community and really assist our community getting vaccinated quickly and safely. So that's the exciting news on the vaccine side. And I must just finish off very quickly with a big shout out to our team of volunteers, our dispatchers, our responders, the guys working in the ambulances, the guys answering the phones, phoning the patients, etc. It's been an incredible effort from them. It's very important to remember that most of them are volunteers. These are people who are giving up of their free time to go out to transport COVID patients to hospital, to call COVID positive patients. They really are an amazing group of people, and I take my hat off to each and every one of them and salute each and every one of them for the incredible work that they're doing. Thank you,
Lance, thank you so much. Thank you so much for your presentation and for the incredible dedication of Hatzola at this critical time. We're about to begin our Tehillim. Before we do, I just want to thank Dr. Friedland, Professor Schoub, Dr. Noach, and Lance Abramson for your presentations today. I think when you look at the panel that we've had today and you see the level of talent and reach and contribution that our community is making to South African society, I think that we can all draw encouragement and pride from that. And thank the outstanding panelists for everything that they're doing for our community and for our country. And now we move to the final part of our discussion and gathering today, and that is the spiritual response. Because you know, as I said before, as Jews, we know that we are in Hashem's hands, and that doctors cannot heal and vaccines cannot protect without Hashem's blessings. And so it's so important for us to respond spiritually to what is going on. And we say in the Rosh Hashanah and Yom Kippur davening, the power to change a situation of difficulty and challenge lies in three things: uteshuva, utefillah, tzedakah. The power of improving our deeds, the power of charity, to give tzedakah. We should all be giving more tzedakah, giving our 10%, giving tzedakah and supporting those in needs. That's a tremendous merit for ourselves, for our community. And the power of improving our deeds. Each one of us should think about something that we can do, a mitzvah that we weren't doing, to take it on now, and to use this time to reflect and to become better and stronger in everything that we do, in all of our mitzvahs. Think of something practical to take on. I want to say to everybody here today, think of something practical, some new mitzvah, something that you can do to take on during this time, whether it's in the area of davening, or it's an area of charity, of Shabbos, of kashrut, or any area, not speaking kindly to one another with gentleness, not speaking lashon hara, mezuzah, whatever it is. Let's think of things that we can do, especially in the way that we treat one another with kindness and with respect and with dignity, and not speaking negatively about others, and reaching out to one another with kindness and support during this time of enormous challenge. And of course, the power of prayer. We're going to say Tehillim now together. There are two paragraphs of Tehillim. We're going to put the Tehillim on the screen, and I'm going to say the Hebrew words. Please, at home, pray along with me in the Hebrew or the English. The slide has it on the screen, and please follow along, and let's daven together. We're going to say two chapters of Tehillim, Tehillim 121 and Tehillim 130, and then afterwards we're going to pray for a list of cholim, of sick people who are suffering from COVID at this point, and we're going to pray together for them. I think it's so important that we join together in this time of tefillah. So I'm going to start with the first Tehillim here, and please say along with me at home. Shir l'malo sesainai el ha'arim me'ayin yavo ezri. Ezri me'im Adonai, Oseh Shamayim v'aretz, Al yitein lamot raglecha, Al yanum shomrecha, Hinei lo yanum v'lo yishan shomer Yisrael, Adonai shomrecha, Adonai tzilcha, Al yad yaminecha, Yomam hashemesh lo yakeka, Ve'yareach balayla, Adonai yishmorcha mikol ra, Yishmor es nafshecha, Adonai yishmor tzeischo voecha, me'ata ve'ad olam. We're now going to say Tehillim 130. Shir hamalois mimamakim karasicha Adonai, Adonai shima bekoli, Tiyena osnecha kashuvos lekol tachanunai, Im avonos tishmor ya Adonai, miyamo lekimcha selicha, leman tivarei kivisi, Adonai kivsa nafshi, velide varo chalti, Nafshi l'Adonai mishomrim laboker, shomerim laboker, Yachel Yisrael el Adonai, Ki im Adonai hachesed ve'arbei moi fedus, V'hu yiftes Yisrael mikol avonosav. Okay, we're now going to daven for the cholim. We have a list of names, which I'm going to read, and please read along with me. And also in the days ahead, say Tehillim every day, daven for our community, for our country, for our world, that Hashem should bless us all with health and with healing. Mishaberach avoseinu Abraham, Yitzchak, v'Yaakov, Moshe, Aaron, David, u'Shlomo, hu yevarech v'yerape es hacholim, Kela Baslova, Sarah Rivka Bas Yehudis, Basia Bas Etel, Avrona Bas Elisheva, Leah Bas Esther, Meryl Bas Nacha, Yehuda Leib Ben Genesia, Nava Sarah Bas Tamar, Shaina Ayla Bas Chava Shoshana, Shimon Ben Avraham, Ruvain Ben Batia, Tuvia Ben Rus, Chaya Fega Ben Bas Miriam, Harav Menachem Mendel Ben Henka, Keren Bas Malka, Rina Bas Mina, Yechiel Ben Tzipora, Shimon Moshe Ben Soralea, Shoshana Devora Bas Chaya Chana, Shemuel Ben Penina, Ruven Ben Sarah, Shlomo Ben Beila, Ze'ev Ben Hena Fruma, Rivka Bas Chaya, Chaya Bas Sarah, Yochevet Bas Batia, Mordechai Ben Tzila, Ze'ev Ben Hena Fruma, Lezer Bas Ben Ita, Salava Bas Chava, Ruben Pinchas Ben Chaya Freda, Yisrael Ben Beila, Chaim Yaakov Ben Chava Hilara, Eliezer Ben Eta, Reina Bas Rochalea, Menachem Mendel Ben Henka, Aryeh Ben Simcha Reina, Nachum Shmuel Ben Aviva, Chava Tzriel Bas Rochel, Eliyahu Ben Rochel, Rochel Bas Daphne Vesila, Bas Rochel Cinda, Bas Tzelas, Colin Ben Chana, Sarah Chava Bas Rivka, Raza Yenta Bas Fruma, Yerach Miel Pinchas Ben Gila, Rana Bas Rochel, Michael Ben Freis, Michael David Ben Freis, Sarah, Avram Ben Miriam, Raphael Moshe Ben Ariela, Aria Levi Ben Esther, Ze'ev Halevi Ben Fruma, Menachem Ruven Ben Yehudis, Ben Pesa Yehudis, Shira Li Bas Sarah, Chana Bas Etka, Shulamis Bas Chava, Sirisa, Aria Halevi Ben Esther, Sharon Ben Freda, Simcha Tuvia Ben Chana Malka, Chaim Ruvain Ben Aliyah, Ilana Bas Rus, Aria Halevi Ben Esther, Dubela Bas Raska, Chaya Chatziva Bas Avram Avinu, Chaim Shmaryahu Halevi Ben Rochel Malka, Agonarav Baruch Mordechai Ben Hinda Malka, Leah Bas Rivka Malka, Yona Ben Etka, Yitzchak Moshe Ben Rochel Reza, Asher Ben Avraham, Eitan Ze'ev Ben Leah, Asfira ben Manya, Shoshana Devora, Basa Chaya, Chana Ze'eva ben Sora Duba, Natanya Bas Elisheva, Andreas Shuchbi, Susana Bas Shushana, Aria Halevi ben Esther, Ruven Pinchas ben Chaya Freda, Chaya Leah Bas Yafa, Sarah Elisheva ben Rochel Guta, Moshe ben Yehudis, Hilton Orton, Talia ben Avram, Bracha Bas Leah, Hirsch Getzel ben Chava, Eliezer ben Bracha, Devora Bas Rivka, Tzipora Bas Devora, Binyamin ben Ita, Bas Pesa, Bas Sarah, Avrona Bas Elisheva, Rochel Bas Marta, Chana Bas Esther, Moshe ben Cynthia, Yisrael ben Miriam, Ziva Bas Yehudis, Ba'avur shanu mispalalim ba'avura, Makadosh Baruch Hu yomale rachamim alehem, lahachlimam al rafu esam alach yosam v'yishlach lehem meira rafu shlema min hashamayim, lechol averem lechol gidehem besor shar cholei Yisrael, rafu nefesh, rafu guf, ashta ba'gala bizman kariv, v'nomara mehein. We wish them all a rafu shlema. May Hashem bless us all, bless our community, our country, and our world with health and with healing. Let us continue as a community to take every precaution, to be so careful, to follow all of the health and safety protocols, and to daven and to do mitzvahs and to give tzedakah, and let us stand together and with Hashem's help, we will face this great challenge, and with His blessings come to the other side of it, in health and with healing. God bless you all, and thank you so much for being part of it today.